Everyone, I'm presenting on behalf of Medicine One. Presenting a 63-year-old male farmer who presented with history of snake bite in the left little finger at 7:30 a.m. on 16th of August this year. So within seconds, a tourniquet was applied around the little finger with a cloth piece. It happened while he was cutting grass in the field. He witnessed the snake and there was pain and bleeding immediately following the bite. Within seconds, tourniquet was applied around the little finger, and 5 minutes later, tourniquet was applied over the forearm with a towel. He was made to walk to the car for around 750 meters, and 15 minutes later, another tourniquet was applied around his arm with a wire. So by this time, the son had noticed progressive local swelling, and he presented to CMC ED 40 minutes after the initial bite. There was no history of ptosis, double vision, difficulty in breathing or walking. At presentation, his vitals were stable, pulse rate of 90, blood pressure of 110 by 80 millimeters of mercury, and respiratory rate of 20. Systemic examination was within normal limits. His single breath count was 40 seconds and neck holding time was 45 seconds. There was no ptosis. On local examination, there were fang marks noted on the pulp of the little finger on the left hand. There was ecchymosis of skin around the fang marks and swelling of the left little finger from the pulp till the MCP joint. There were 3 tourniquets in situ that was noted. There was no active bleeding from the bite site, no hematuria or bleeding gums. This is how he presented to the ED. The initial tourniquet was applied immediately after the bite, followed by the one on the forearm and one on the arm. So clinical diagnosis that we made was a confirmed snake bite with clinical evidence of local envenoming. We went ahead with the investigations. A 20-minute WBCT was done at 8:10 a.m. when he presented to ED. As soon as he presented to ED, IV line was inserted and samples were taken prior to releasing the tourniquets. So the initial WBCT, which was taken at 8:10 a.m. was negative. His PT-INR was 13.5 and INR of 1. APTT was 21, total WBC of 7,500, hemoglobin of 13.4 and platelets of 2.86 lakhs. So we had a negative WBCT with normal PT APTT values. What will be the next appropriate action and management? Discharge the patient from ED after snakebite prevention education and TT. Admit and observe the patient for any bleeding manifestation or neurotoxicity features for 24 hours. Admit and repeat the WBCT after 6 hours. Keep in priority 3 and repeat WBCT after 6 hours or follow the serpent. Slide. Slide. And what would be the next appropriate action for this patient with a negative WBCT, normal PT-APTT with features of local envenoming? Option 2, admit and observe. Okay. And any other options? Option 3, admit and repeat WBCT after 6 hours. Okay, sure. So coming into what has to be done for this patient, according to the National Protocol for Management of Hemotoxic Snake Bites, all patients with snake bite should be admitted and observed for 24 hours, and coagulation test should be repeated at least twice before discharge. So anybody who presents with no significant envenomation, should have a repeat coagulation profile at 6 hours and 12 hours. If it's normal, after 12 hours with 2 normal WBCTs, you can discharge the patient. If it's deranged, then we go ahead with anti-snake venom administration. This is the WHO guidelines for management of snake bites, and this also emphasizes on need for repeating the 20-minute WBCT frequently and administering the anti-snake venom if there is evidence of any hemostatic disturbances, because the 20-minute WBCT may remain negative in patients with an evolving venom-induced DIC. So we repeated the parameters for our patient after 6 hours. You can see the prior investigations on the right-hand side. The 20-minute WBCT, which was done at 2 p.m., was positive for him. His INR had gone up to 2.54 with a PT of 32.3. APTT was 33.4. Total WBC had gone up to 12,800 from a 7,500. This leukocytosis is a feature of systemic envenomation that is happening in him. Hemoglobin and platelet was within normal limits. He was also noted to have ascending local swelling and a tender axillary lymphadenopathy at this time. So at 2:20 p.m., we administered 10 vials of ASV. A repeat WBCT was done at 8 p.m., which was again positive, and hence a second set of 10 vials of ASV was given. At 2 a.m., the 20-minute WBCT test repeated was negative. However, his INR was still deranged and he had local envenoming, which was progressively worsening. Hence, a third set of 10 vials of ASV was given to this patient. And by next day, 8 a.m., his 20-minute WBCT was negative and there was no further increase in local envenoming. So coming into the discussion, did the tourniquet have a role in delaying his envenoming? If so, are tourniquets recommended as first aid in patients with snake bite? And how to manage a patient who presents with tourniquet after a snake bite? So coming to the role of tourniquets, the main pathway for systemic spread of the snake venom is via lymphatics, and vascular spread can be a minor pathway. So methods that decrease the lymphatic flow have shown to delay envenoming in both animal and human models. So applying a compression pad bandage with pressures more than 60 millimeters of mercury or cooling of limbs are two different methods that have been tried to decrease the lymphatic flow and hence delay the envenoming. According to ancient standard guidelines, treatment tourniquets was a strict part of treatment of snake bite. A ligature, that is strong string, tape, narrow strip of clothing or handkerchief, should be tied at once around the limb above the bitten part was the initial recommendations. And this was how they used to tie very tight tourniquets for patients following the bite. But why a tourniquet is not recommended any longer is because they have shown to have more harm than benefit. Applying a tourniquet post-bite causes concentration of the cytotoxins present in the snake venom in that area, and this leads to increased risk of ischemia, necrosis, and gangrene. There has been increased incidence of amputations associated with applying a tight tourniquets. Risk of massive neurotoxic blockade and circulatory collapse after releasing the tourniquet have also been shown in different studies. The procoagulant venom component that stays within the tourniquet part predisposes to lymph thrombosis, and it gives a false sense of security, thus delaying the patient's hospital visit. So lack of evidence, there is lack of evidence that the tourniquet use translates to a meaningful positive clinical outcome. But as a first aid measure in the field, a compression bandage can be used, but it requires expertise and knowledge, and it tends to lose the emphasis on getting the patient immediately to the hospital. Studies have also shown that up to 40% of the bandages that are applied fail to be retained by the time they reach the hospital. So limb immobilization alone is likely to be as effective as applying a compression bandage. This is a study that was published in 1988 regarding delayed onset of neurotoxicity with dangers of sudden release of tourniquet after a cobra bite. The study was done to study the effects of tourniquet application in 36 hospitalized patients who developed neurotoxic symptoms after a bite with Naja philippinensis, and the tourniquet was applied in 34 out of 36 cases. And abrupt removal of the tourniquet caused worsening of neurological symptoms in 32% of the patients within 10 minutes. 4 patients who were asymptomatic developed symptoms immediately after release of the tourniquet, and respiratory arrest occurred within 10 minutes of tourniquet being released in 4 patients, out of which 1 who was asymptomatic at presentation. So when the tourniquet is applied within 20 minutes of the bite, there was a higher chance of worsening of symptoms on releasing these tourniquets. And the tourniquet applied after 20 minutes, 1 out of 8 developed worsening of the symptoms. So the study showed that application of tourniquet delayed the absorption of cobra neurotoxin into the systemic circulation. Also, that the tourniquet removal rapidly released large quantities of neurotoxins into the systemic circulation, where they were then bound to the motor end plates in large volumes, causing the paralytic effects. Therefore, tourniquet should not be suddenly released if a cobra bite is suspected, and tourniquet should be released under controlled hospital conditions. These were the recommendations of this paper, which was published in 1988. Now, how do we manage a patient who presents to us with a tourniquet in situ? Before releasing the tourniquet, administer ASV if there is an indication to for the same. If, however, if the pulses are absent, then you need to release the tourniquet without any delay. Ensure that an intravenous line and resuscitation facilities are in place before releasing the tourniquet, because the sudden release of toxins can cause neurological and respiratory worsening. Tie a BP cuff proximal to the tourniquet and raise the cuff pressure to above 60 millimeters of mercury to occlude the lymphatics, and then release the tourniquet gradually. Release the tourniquet and then reduce the BP cuff pressure gradually. So take-home messages are: always repeat a WBCT after 6 hours of the first WBCT, even if it is negative. Delayed envenoming is possible and more likely in patients who come with tourniquets applied. Advise against tourniquet application and emphasize on limb immobilization, and release the tourniquet under controlled settings in a hospital. Thank you. Any questions?
Very nice, especially why did you use PTM? That's because the recommendations are you use WBC. So the third time to give the ASP, you used PTM.
Along with
WBCT and non-used.
Yes, ma'am. His WBCT was negative. INR was deranged, but he had worsening swelling. The swelling had extended to almost the entire dorsum of the hand, which was initially only on the little finger. It had extended to the entire dorsum. So worsening clinical local envenomation was the indication in that case to give the third set of ASV.
What was the INR?
1.88, ma'am. WBCT for minor coagulopathy, it has been shown to be not that sensitive. So
that's true. But the studies have shown that even the PTR and daylight and WBCT is normal, they do not develop anything significant bleeding post discharge. And sensitivity and specificity are higher for WBCT. Clinical bleeding and outcome in that PTR.
The local envenoming was the only worsening. Local envenoming was the only.
Next, Alcy will be presenting from Medicine 2, The Miracle.
You already sent it to me. Why did you send it?